So to kick off the afternoon session, we have Professor Bill Evans. So Bill is our Keough-Hesburgh Professor of Economics here at the University of Notre Dame. He considers himself to be and is an applied microeconomist and works on areas of labor economics and the economics of education, public finance, and health economics. He's a co-founder of the Wilson Sheehan Lab for Economic Opportunities, and that lab is a research center that partners with local service providers to provide enhanced and evidence-based research poverty solutions. So we're excited to have Bill join us today, and he's going to talk about reducing readmissions among low-income elderly by addressing the social determinants of health. Bill?
Thanks for the invitation and thanks for the introduction, Melanie. This is an evaluation of a program that was run by Catholic Charities Chicago, attempting to reduce readmission rates in the as part of a care transition program. My co-authors on this are one of our research faculty members at Leo, two of our former Ph.D. students, and a current graduate student in our Ph.D. program. This is work with the Wilson Sheehan Lab for Economic Opportunities, or LEO. We're a research center interested in evidence-based solutions to poverty. And we get that evidence by doing random assignment experiments and some quasi-experimental evaluations of the program's design, either to move people out of poverty or lessen the effects of poverty, one of the major problems being health. We believe that the local social service providers, since they're on the ground, are the ones that have the brightest ideas for how to deal with this perplexing problem. And so we're trying to put some empirical content behind what they're doing. And a lot of our partners over the years have been national organizations like Goodwill, Lutheran Services America, and Corporation for Supportive Housing. We work with a lot of local Catholic charities in Fort Worth and Chicago and Rapid City, South Dakota. And recently we've been starting to work with a lot of local governments such as King County, Santa Clara County, and Monroe County in New York to do some evaluations of their work. We're going to talk about today the community-based care transition program. And the background for this is the high cost of hospital readmissions in the Medicare program. So in 2017, there were 11 million inpatient stays in Medicare, generating about $135 billion in costs. Unfortunately, 20% of these discharges have an unscheduled readmission within 30 days, generating costs of $23 billion. The Centers for Medicare and Medicaid are interested in trying to reduce these. So two different programs have been recently enacted. One was the Hospital Readmission Reduction Program, which reduced reimbursements for hospitals with excess readmissions in 6 different DRG categories. And the one we're going to talk about today is the Community Care Transition Program, which was started also in 2012. This program had 100 demonstration projects across the country of many different interventions designed to reduce readmissions by improving the transition from the hospital to home. The goal of the program was to reduce readmissions by 20%. The vast majority of the programs had no measurable change in outcomes. Many of them were very light touch interventions, like telephoning people for following up with them after they made it home. And one interesting characteristic about the programs is that most of them were managed by medical professionals, such as nurse practitioners. The program we're going to talk about today was run by Catholic Charities in 4 hospitals in the Chicago Southland area called the Southland Coalition for Transition Care. This is a relatively challenging area compared to the rest of Chicago in that it has 30% higher poverty rates. It has 3 times the rate of African-American residents as the rest of Chicago. The CCT program that they initiated was part of the original demonstration that started in 2012. But this program was somewhat different from other transition care programs in that first, it was run solely by social workers. They had in-hospital and home visits to patients. And most importantly, the program was designed to address the social determinants of health. Catholic Charities, in their scan of what was happening to the patients that they've been in contact with in the past, And many times their life got in the way of their medical care. And as a result, that's what led to a hospital readmission. So what does a social worker do? They go home, they meet with the patient, they make sure that they have food in the refrigerator. If they don't, then they contact Meals on Wheels and deliver food to the household for a couple weeks after they've been back. They make sure that they have transportation back to their follow-up appointment. They make sure their prescriptions are picked up at the store. They make sure someone else is going to be visiting with them to make sure that they can check in on the health of the patient. So what they're really worried about are these non-medical factors that could be detrimental to the progress of their medical condition. The program we're going to evaluate for them was started in July of 2012. They served a broad base of Medicare patients, but they did not serve those with a mental illness or substance abuse diagnosis. And primarily, the big group that didn't serve those in Medicare Advantage plans. They ended up treating 16,000 patients through the end of 2015, and we're going to evaluate that 2012 to 2015 period. At its peak, they were serving about 50% of those discharged from the hospital in Medicare, and the average cost to Catholic Charities was about $370 a patient, and that number will become important in just a moment. Our evaluation study is what's called a difference in difference model. We have the time series of readmission rates in the 4 treatment hospitals over time. We don't know how much of the change was due to the intervention and how much were due to secular forces. So we need a comparison sample. There are roughly 80 hospitals in Cook County, 80 other hospitals. And what we're going to do is match each one of these hospitals with the 4 treatment hospitals, select as a comparison group those hospitals that have the same pre-treatment trends and the readmission rates and traditional Medicare discharges. Over this time, Medicare Advantage is heavily cannibalizing traditional Medicare, and so discharges are dropping rapidly. So we want hospitals that have the same type of environment as the 4 treated hospitals. And we're going to take a look at them as a comparison group. We ended up with 18 hospitals that matched on the pre-treatment trends in a statistical sense to 4 treatment hospitals. And the data that we're going to use is a universe of Medicare Part A claims that allow us to measure quite nicely readmission rates to any hospital that the people end up going to. This is a basic graph of some trends that are occurring in the program. We're going to take a look at 2 years before the program through the intervention in 2015, where it comes into effect in August and July of 2012. The black line is the total number of CCTP eligible discharges in the treated hospitals, and notice it's declining rapidly in this time period as Medicare Advantage eats into traditional Medicare. The gray dotted line is the fraction of discharges in these hospitals that are treated by CCTP. There's a pretty rapid ramp up in the first 6 months, but notice that there's a slow, steady increase after that to the point where about 50% of discharges are actually covered by this program in the Medicare population. The gray solid line are the total number of discharges in our 18 comparison hospitals. And notice, since we selected these hospitals to have the same trend in this variable, they look like the same decline that's occurring in the treated hospitals over time. The easiest way to think about what's going to happen in this is to take a look at the graph of monthly 30-day readmission rates from 2010 through the end of 2015. The black line are the treated hospitals. The gray line are our comparison hospitals. And notice those track each other reasonably well in the pre-treatment period. And then in the post-treatment period, there tends to be some daylight between the treated and the control hospitals. It's a little bit easier to see if we take a look at the differences in these means. So this is just the raw difference, treatment minus control. And we fit a line through this pre-treatment period. And notice that line is pretty flat. But once we put in the same difference in the post-treatment period, this line is declining throughout, although there's tremendous amount of month-to-month variation. And so this is pretty nice because there's been a slow ramp up in the fraction of patients that are being treated. And so as a result, this is at least suggestive that the program is delivering as promised. We end up estimating a treatment on the treated model, estimating exactly what is a change in the reduction in readmission rates for people that were engaged in the CCT program. I'll just talk about the results for 30-day readmission rates. So we follow the people for at least 30 days after their discharge. The black lines here represent 95% confidence intervals. And what we're finding is that participation in the program reduced your probability of a readmission in 30 days by about 17 percentage points. The effect is largest early on and it declines over time, but even after 180 days, there was still measurable and statistically significant decline in the probability of a readmission. These readmissions generate costs. So most people have no readmission, so the cost is zero. Those that do, the cost is relatively high. So another thing we can take a look at is the change in the cost per readmission for someone that participated in the CCTP program. When you reduce a readmission, it's a fairly large change in cost. So on average, that turns out to be about savings of $364 per person treated, which is essentially the same number that it costs to run the program. So in this particular case, the program essentially pays for itself in the form of lower readmission costs. One interesting aspect about this is that Catholic Charities got into this because they thought that the social determinants of health were an important contributing factor to readmission rates. And so one question is whether this intervention actually reduced health disparities. Because we're working with claims data, we don't have too much information about the underlying characteristics of the population. So for example, we're not going to have education or income, but we do have some proxies. If we take a look at 30-day readmission rates for two separate groups, let's take a look at white non-Hispanic versus Blacks and Hispanics. The minorities tend to have 28% higher 30-day readmission rates in the pre-treatment period. And so if this program is working as expected, we should see much bigger declines for the more vulnerable group. As a proxy for income, we can take a look at those that are dually eligible for Medicaid as well as Medicare and compare those to those that aren't dually eligible. They're only in the Medicare program, and the dual eligibles are substantially higher readmission rates. So the question is, are we getting bigger results for those that are most vulnerable? And the answer is decidedly yes. If we take a look at the results and the percentage change in 30-day readmission rates for white non-Hispanics, we're essentially getting nothing. Although it looks like there's a 2.7% increase, the standard error is so large we can't reject the null, but there's no effect. In contrast, we're getting about a 26% decline in readmission rates for Blacks and Hispanics. And so the program is definitely delivering something for those that are most vulnerable. If we were to compare the dual eligibles with those that are not, all of the effect is coming from those that are dually eligible, and we're getting a 35% reduction in readmission rates for them. Those that aren't, which tend to be much higher income, we're only getting about an 8.7% reduction, and that ends up not to be statistically significant. So in terms of what the program promised to do, it's delivering as promised. It's helping those that are most vulnerable. It's reducing the readmission rates, and it's doing so in a way that essentially is paying for itself because of reduced medical care costs in the future. And so that's what we have, and I'm done.
Great. So thank you so much, Bill. We don't have any questions in the chat, but again, people, if you have any questions, you're welcome to put them in at any time. We'll get those questions to Bill and get some answers back out. I think that's, that's really interesting data, Bill. And I guess I quite frankly hadn't realized how much there really was. I didn't realize the health aspect of what Leo does, quite frankly. And so this is really great and really educational for me personally, and I hope for others as well. And obviously a goal of this would be, again, to facilitate collaboration across the state. And so with our other Indiana CTSI partners, knowing what Leo does, especially I would say in the healthcare arena, I think is a really important thing. And so hopefully everybody else learned something here, and maybe you're going to get yourself a new collaborator from here. Oh, could this program be more cost effective if it focused on URMs and dually eligibles?
Yeah, so we take a look at that in the paper. So the interesting aspect of it is that there is a fairly broad-based decline in readmissions based on severity. So more minor cases seem to have a decline, as well as very major cases that have a priori high readmission rates. But there is tremendous amount of cost savings for the high readmission cases. So although the percentage decline is going to be the same, you're going to get a lot more money, because when they were readmitted, they tend to be much more expensive cases. So it depends upon what the hospital's objective function is. If it's to save money, you can concentrate on those cases that have the highest probability of readmission, which are going to be more severe cases, underrepresented minorities, dually eligible. But if they're under pressure from Medicare, and what they really need to do is just reduce the readmission rates, then you can have a much more broad-based program. And so it's a function of what the objective criteria is going to be for the hospital itself, but sort of certainly focusing on this for particular groups are going to get much bigger impacts.
Great. Thank you, Bill. So we're going to move on to our next speaker. But again, if you've put a question in the chat, we'll get to it, and we'll get those questions answered for you. So thanks, Bill, for your time. We really appreciate it.